Hello, I'm Dr. Barry Bertolet, an interventional cardiologist in Tupelo, Mississippi. Today I'll be talking about Biotronic stents, the new kids with a 4 French delivery system. First, I'd like to thank Dr. Walker for his invitation to present to the new Cardiovascular Horizons digital education series. Now back to the topic. With regard to 4 French intervention, if you're doing great with your 6 French system, why do you care about a 4 French system? And the answer is it has to do all about the size here. So when we look at the size that is created with a 4 French system as compared to a 6 French system, we're looking at a 45% smaller puncture hole. And with that smaller puncture hole, we're going to see less access site complications. We're going to see less need for closure devices. We will see less trauma to the blood vessel, which may be important for future interventions, as well as less time required in the hospital due to faster ambulation. And when we add these four things together, that translates into less cost of care. Now, what do you have to have in your toolbox in order to perform that 4 French peripheral intervention? First, you got to have a deliverable but sturdy 4 French delivery guiding sheath. You have to have an 014 or 018 workhorse guide wire. I will not talk about any specifics on the guide wire because I know that these are near and dear to our hearts, and so you have your favorite. But if you pick any in this size, this will work out quite nicely. You have to have a PTA balloon that's able to treat longer lengths, and then you have to have a stent that's easy to deliver, conformable, fracture resistance, and has a low restenosis rate. This would be the ideal circumstance to perform 4 French peripheral intervention. So within the Biotronic framework here, we do have a guiding sheath. This is the Fortress guiding sheath. It is coiled reinforced. The nice thing about this coil reinforcement is that if you do go up and over at that top peak, you're not getting compression of the sheath. It maintains its round shape, and so as you're passing equipment in and over the aortic bifurcation, it passes very smoothly. In addition, to add to that smoothness, there is a PTFE liner within the sheath. And this allows the equipment to pass in and out with a lower friction rate. The sheaths come in a 45 and 100 centimeter length. I personally use the 100 centimeter length commonly when I do my below the knee interventions. So when we're thinking about below the knee intervention and we have that 4 French Fortress sheath in place, what can we use to perform the intervention? Well, when we think about things outside of Biotronic, we do have the CSI Diamondback atherectomy. You can use the 1.25 millimeter burr, and this can be used through the 4 French sheath quite easily, and therefore perform your below the knee atherectomy. You also can use any 014 PTA balloon, and you can use the 018 4 millimeter up to 200 millimeter length Lutonix drug-eluting balloon. So all of these are on the table when you're doing your below the knee intervention. With regard to below the knee stenting, we now have the TAC endovascular below the knee stent, which is now FDA approved. Within a catheter, you can have 4 of these TAC stents, and you can treat 4 lesions anywhere from a 1.5 to 4.5 millimeter size in the vessel, all through this 4 French sheath system. With regard to the Biotronic balloons, there is the Patheo balloon, and this balloon is really designed to operate through a 4 French system. It has several unique characteristics. One is that it's got a unique stiffening wire within the shaft of the balloon. And this allows you to have some pushability to cross some perhaps calcified lesions in these tibial vessels. Also, the balloon, when it's in its deflated state, is hydrophilic coated. This allows the passage of the balloon down the blood vessel. But once the balloon becomes inflated, there are sections of that balloon which are not hydrophilic coated. And then this allows there to be some grip within the blood vessel so that you're not seeing any kind of slippage when you inflate the balloon. The other nice thing is that the way that this balloon is designed is that there's a rapid de-inflation. And so once you pull negative on the balloon, you're going to see that that balloon collapses quickly, and you're able to retrieve the balloon and then move on to the next part of the procedure. But what about above the knee interventions? And here's where Biotronic is taking the lead. They really have the only devices that allow you to do SFA, large popliteal interventions through a 4 French delivery system. First, they have the Passio 18 balloon. Now, this is, again, a tapered balloon. It's got a 1.3 millimeter crossing profile. It's also got this patchwork hydrophilic coating. So again, it's completely coated in its deflated state, but as it gets inflated, then there are some areas that are not hydrophilically coated, preventing slippage when the balloon is inflated. This balloon is available in a size as small as 2 millimeters up to 7 millimeters, and from a length of 20 millimeters all the way to 200 millimeters. To complement that, there is the Biotronic Pulsar 18 stent. This is a nitinol self-expanding stent that has a strut thickness of 140 microns. This is the thinnest available in the United States. And then this is designed so it has a low chronic outward force. We'll talk about that in a moment. This stent is available in sizes anywhere from 4 millimeters to 7 millimeters in lengths from 20 up to 200 in length. Now, with regard to that low chronic outward force, this in theory should lead to faster reendothelialization, less vascular and tissue injury, and less restenosis. And so when we look at the amount of newtons applied per millimeter in the stent world, we can see that the Pulsar 18 on the left side of this slide shows the lowest degree of force, and then compared to the highest, which is the Life Stent XL by Bard, we can see now on the opposite side is that if we use 1 millimeter stent oversizing in a vessel and then we look at 90 days, we can see that there's much more tissue injury with the Life Stent as compared to the Pulsar stent. So a high chronic outward force compared to a low chronic outward force equals a big difference when we look at vascular injury and then restenosis that is subsequent to this. And so the Biotronic stents are designed, engineered to deliver a low chronic outward force. So this Pulsar 18 stent is deliverable through an easy hand deployment. It's just a crank with a pistol grip. The stent is quite conformable, and the other thing that it is coated with a silicon carbide coating, which decreases the platelet adherence, and then it also facilitates reendothelialization. If any of you have used these stents, you'll notice that this silicon carbide coating creates a very pretty, almost rainbow-like mosaic when you look at these stents when they're deployed. An older stent, which is but also in this same family, is the Astron Pulsar stent. This is a pin and pull variety of the Pulsar 18. Still 4 French compatible, but these stents are shorter in their length, only going up to 80 millimeters. They're also a bit thicker. They're 155 microns in their strut thickness as compared to the 140 that we saw with the Pulsar 18. But they still have this very low chronic outward force with a Newton force of 0.19. So does this 4 French delivery system actually work in real life? So that was actually studied in the Forever study. And in this particular study, we looked at a pure 4 French intervention in the SFA popliteal area. This looked at the Fortress sheath, This looked at the Astron Pulsar sheath, the shorter stents, the Astron Pulsar stent, where they're shorter, and then also the Pulsar 18, which are again these longer stents in these scenarios. When we looked at the patient demographics, these were what you would typically expect for a PAD population. A lot of these patients were diabetic, 35%, had dyslipidemia, 55%, 65% had hypertension, with 60% being smokers. Now, on the other side of this is that the lesion characteristics, we see that 20% were occlusions, 30% were calcified lesions. The average length of this was 7.1, again, shorter with the Astron stent, longer with the Pulsar 18 stent. And most of these were task A and B lesions, as this was an exploratory trial. And when we looked over time, we saw that at 12 months, we saw that the primary patency rate was 81%. That's quite good with that. When we looked at calcified versus non-calcified, we really didn't see any difference in the outcome of these stents in this long-term follow-up. And then when we looked at the freedom from TLR, we again saw that to be 89%. So we saw some improvement in the patients with long-term good outcomes. And if we take this trial out to now 24 months, we're actually looking at, there was a 72.3 primary patency rate and a freedom from TLR of 82.7 over 2 years, again with no difference between the calcified and the non-calcified lesions. Now, how does this stack up to the other stents that we use? So here's the 24-month data looking at all the bare metal stents that are presently on the market. You can see at the top is that we have the Forever trial. In this, we saw the average length, again, 7.1, 21% occlusion rate. As we look down that column, we can see that this is quite comparable with other studies that were there. We see that there was a 100% success rate. And when we go out to the 24-month follow-up, when we look at this primary patency rate, we see this to be in the low to mid 70s, which is quite comparable to the other stents that are on the market. And then we can see that the fracture rate here, highlighted at the bottom of the slide, is at 4.2%. And this is in line with some of the other stents that have been studied in this area of the blood vessel. Now, what about if we go out to a broader population, something beyond the task A and B lesions? There was this PEACE all-comers registry. And if you look at the lesion length here, we can see now we're getting up to 11.2 centimeters. And then we can see that the occlusion rate was 57%. And so this is more likely what you and I would see in our regular practice. So when we look at the 12-month primary patency rate here, we can see that to be 79.5%. Nearly 80% are doing quite well. 81% of these patients had freedom from TLR. So again, a very nice outcome in 12 months. We also looked at the SFA versus the popliteal outcome in this particular registry and saw that it was equivalent. Additionally, there was a task D registry. This is a small study, only 22 patients, but in this there was 100% of these were CTOs. The average length of the lesion was 24.5 centimeters. So this is a really high-risk group of people. Technical success here, 100%. At 1 year, the primary patency rate was 77%. Now, I just told you in an all-comers trial that primary patency rate was 79%. So here with longer lesions, all total occlusions, we're really not seeing much in a difference in the primary patency rate at that 1 year mark. So these are not only good acute stents, but they're quite durable over the long run. So here's an example of a patient from one of the clinical trials that we were involved in. Again, this is a focal SFA lesion that you can see, quite tight, maybe about a 90% stenosis. What you can't maybe appreciate in this particular slide is there's a good degree of calcification involved in this particular stenosis. And then after balloon angioplasty and then placement of the Biotronic stent, we can actually see a very nice clinical result. Again, right about that 80 mark on the tape. So before, after, very nice result. So in conclusion, we find that 4 French peripheral angiography and intervention is not only feasible, but it's safe. There is now equipment available to allow complete 4 French intervention, both below the knee and now above the knee, with comparable outcomes to your 6 French systems that you're accustomed to. But the advantage of going to this smaller French size is that we're going to have less vascular injury, we're going to have less bleeding, we're going to have a quicker time to ambulation, and less cost of care. Again, I thank you for your attention, and again, thanks to Dr. Walker for his kind invitation.